Okay, let's talk about purine catabolism into hypoxanthine and then xanthine and then uric acid via the enzyme xanthine oxidase.
Sure, purine catabolism is the process where purine nucleotides are broken down into uric acid, which is excreted from the body. First, the purines are broken down into hypoxanthine. Then hypoxanthine is oxidized into xanthine by the enzyme xanthine oxidase. Finally, xanthine is further oxidized by the same enzyme into uric acid. This is the final breakdown product in humans, which is then excreted through urine. Let me know if you'd like to dive deeper into any part of that process.
So, allopurinol and febuxostat, they,
Allopurin
they work on xanthine oxidase.
Exactly. Both allopurinol and febuxostat are medications that inhibit xanthine oxidase, the enzyme that converts hypoxanthine to xanthine and then to uric acid. By inhibiting this enzyme, these drugs reduce the production of uric acid in the body, which is helpful for conditions like gout or hyperuricemia. Allopurinol is a more traditional option, while febuxostat is a newer alternative that can be used in patients who may not tolerate allopurinol as well.
So, when the xanthine oxidase enzyme is inhibited, what
When
happens to the hypoxanthine?
When xanthine oxidase is inhibited, hypoxanthine and xanthine can't be further converted into uric acid. Instead, they build up and can be excreted more easily by the kidneys. This reduces the overall uric acid levels in the body, which helps prevent gout attacks and other complications related to high uric acid.
So, hypoxanthine can also be excreted by the kidneys? Then why convert it to uric acid?
Great question. The main reason purines are naturally converted all the way to uric acid is that humans lack the enzyme to further break down uric acid into something simpler. In many other animals, uric acid can be broken down further, but in humans, it's the end product of purine metabolism. On its own, uric acid can act as an antioxidant, but in excess, it crystallizes and causes problems like gout. So the conversion to uric acid is just the body's natural endpoint for purine breakdown, even though hypoxanthine and xanthine are easier to manage by the kidneys.
So the clearance of hypoxanthine and xanthine is easier by the kidneys than uric acid.
Yes, exactly. Hypoxanthine and xanthine are more soluble and easier for the kidneys to handle and excrete compared to uric acid. Uric acid is less soluble, especially at lower temperatures, which is why it can form crystals in joints and tissues, leading to gout. That's why inhibiting xanthine oxidase helps. We avoid the buildup of uric acid and keep more of the more easily excreted intermediates.
Now, the animals have another enzyme similar to the drug rasburicase, which is a urate oxidase and turns uric acid into a lanthorine, which is also easily excreted in the urine.
Exactly. Many animals have an enzyme called uricase, or urate oxidase, that breaks down uric acid into allantoin, which is highly soluble and easily excreted by the kidneys. Humans don't have that enzyme, which is why we end up with uric acid as the final product of purine metabolism. Some drugs like rasburicase are actually forms of that enzyme and can be used to break down uric acid in certain medical conditions, especially when rapid reduction of uric acid levels is needed.
So, how much of hypoxanthine is actually salvated through the purine salvage pathway?
Good point. The salvage pathway is another way the body deals with purines like hypoxanthine. Instead of breaking all of it down into uric acid, some of the hypoxanthine is recycled back into new nucleotides. The enzyme responsible for that is called hypoxanthine guanine phosphoribosyl transferase, or HGPRT. How much hypoxanthine gets salvaged versus broken down depends on the body's needs. If there's a high demand for new nucleotides, for example, during cell growth, more hypoxanthine will go into the salvage pathway. If not, more will be broken down into uric acid.
So, can you describe the salvage pathway briefly?
Sure. The salvage pathway is all about recycling purines, like hypoxanthine and guanine, back into nucleotides, rather than breaking them down completely into uric acid. The key enzyme here is HGPRT, which attaches a sugar phosphate group to hypoxanthine or guanine to form nucleotides like IMP or GMP. These nucleotides can then be reused for DNA and RNA synthesis. So instead of wasting purines by fully breaking them down, the salvage pathway helps the body conserve energy and resources.
So, attaching a phosphoribosyl moiety to hypoxanthine turns it to inosine monophosphate.
Exactly. When a phosphoribosylate group is attached to hypoxanthine, it becomes inosine monophosphate, or IMP. That's a key building block for making new purine nucleotides that the body can use again for DNA, RNA, or other cellular processes. It's an efficient way for the body to recycle purines instead of just breaking them all down.
And guanine by itself can be salvaged and not go through making hypoxanthine or xanthine. It just body attaches a phosphoribosyl group to it and it becomes guanosine monophosphate again.
Exactly. Guanine can be directly salvaged by attaching a phosphoribosyl group to it, forming guanosine monophosphate, or GMP. That means guanine doesn't have to go through breakdown into hypoxanthine or xanthine first. So both hypoxanthine and guanine have direct salvage pathways, keeping things as efficient as possible for the cell.
So when adenosine and guanosine are being broken down by the body, I mean the purine metabolism pathway, what happens to each molecule step by step?
Alright, let's break it down step by step. When adenosine is broken down, it first gets converted into inosine by removing the amino group. Inosine is then broken down into hypoxanthine. Hypoxanthine is then either salvaged or converted to xanthine by xanthine oxidase. Finally, xanthine is converted into uric acid, which is excreted. For guanosine, it's a similar process but with a slight difference. Guanosine is first converted into guanine by removing the sugar group. Guanine is then broken down into xanthine by removing the amino group. From there, xanthine goes down the same path to become uric acid. So both adenosine and guanosine end up as uric acid eventually, unless they're salvaged along the way.
So guanosine cannot be converted to hypoxanthine.
That's correct. Guanosine doesn't go through hypoxanthine at all. It follows its own path, guanosine to guanine, then guanine to xanthine, and then xanthine to uric acid. Hypoxanthine comes from the adenine-based breakdown pathway, not from the guanine-based one. They run parallel, but they don't intersect at that step.
So which nucleotides are converted to each other by adding an amine group? Like inosine, adding an amine group turns it into adenosine. What else? What other nucleotides go through a similar metabolic pathway?
Great question. So, as you mentioned, inosine can become adenosine by adding an amino group. Similarly, xanthine can become guanine by adding an amino group as well. This amino group transfer is a key part of interconverting purines during metabolism and the salvage process. So in short, inosine can gain an amino group to become adenosine, and xanthine can gain an amino group to become guanine.
How about pyrimidines?
Pyrimidine metabolism is a slightly different process from purines. Pyrimidines include bases like cytosine, thymine, and uracil. In the salvage pathway for pyrimidines, cytosine can be deaminated to uracil, and uracil can be converted back into a nucleotide form for reuse. Thymine also has its own salvage pathway. However, pyrimidines are more easily broken down into smaller water-soluble molecules like beta-alanine or beta-aminoisobutyrate, which are then excreted or used in other metabolic processes. So unlike purines, pyrimidines don't end up as a single final waste product like uric acid. They are broken down more completely or salvaged for reuse.
So, between allopurinol and febuxostat, which one is the first line treatment for gout or hyperuricemia and why?
Allopurinol is typically the first line treatment for gout and hyperuricemia. It's widely preferred because of its long history of effectiveness and safety. Febuxostat is generally used as a second line option if someone can't tolerate allopurinol or if allopurinol doesn't work well enough. One reason allopurinol is first line is that febuxostat has been linked to a higher risk of cardiovascular issues in some studies, so it's reserved for specific situations. But both work similarly by inhibiting xanthine oxidase to lower uric acid levels.
What is the initiation and maintenance dose strategy for beginning and then continuing allopurinol or febuxostat in a gout patient?
For allopurinol, the typical strategy is to start with a low dose, often around 100 milligrams per day, to reduce the risk of triggering a gout flare. The dose is then gradually increased every few weeks until the target uric acid level is reached, which is usually below 6 milligrams per deciliter. The maximum dose can go up to 800 milligrams per day if needed. For febuxostat, the starting dose is often 40 milligrams per day, and the dose can be increased to 80 milligrams if the target uric acid level isn't achieved. Both strategies focus on slowly adjusting the dose to avoid sudden drops in uric acid, which can actually trigger flares.
What is the drug interaction between allopurinol and azathioprine? And is there a similar interaction between febuxostat and azathioprine?
Yes, there's a significant interaction between allopurinol and azathioprine. Allopurinol inhibits the enzyme that breaks down azathioprine, which can lead to much higher levels of azathioprine in the body. This increases the risk of severe toxicity, especially bone marrow suppression. Febuxostat has a similar interaction. It also inhibits the breakdown of azathioprine, posing the same risk of toxicity. Because of this, both drugs are generally avoided in combination with azathioprine, or the azathioprine dose must be significantly reduced and monitored closely.
Does this interaction happen in everybody?
Yes, the interaction is due to how the drugs affect the same metabolic pathways, so it applies to everyone who takes them together. Both allopurinol and febuxostat block the enzyme that would normally break down azathioprine, so the effect is pretty consistent across individuals.
So, which enzyme is that?
The enzyme involved is xanthine oxidase, which both allopurinol and febuxostat inhibit. This enzyme also helps break down azathioprine's active metabolite. When xanthine oxidase is inhibited, azathioprine builds up, increasing the risk of toxicity.
How about 6-mercaptopurine? Does it also have the same interaction as azathioprine with allopurinol?
Yes, exactly. Azathioprine is actually metabolized into 6-mercaptopurine in the body, so the same interaction applies. Allopurinol or febuxostat can increase the levels of 6-mercaptopurine, leading to potential toxicity if the doses aren't adjusted.
What is the enzyme that is genetically deficient in some patients, and in those patients, azathioprine can lead to severe bone marrow suppression?
That enzyme is thiopurine methyltransferase, or TPMT. People with low or absent TPMT activity can't metabolize azathioprine or 6-mercaptopurine properly, which can lead to severe bone marrow suppression if standard doses are given. That's why genetic testing for TPMT activity is sometimes recommended before starting those drugs.
Okay, so now that we have a general understanding of the purine catabolism pathway and the roles for allopurinol, febuxostat, and rasburicase in the purine catabolism pathway, let's move on to the treatment of tumor lysis syndrome. What can we do in terms of prevention from tumor lysis syndrome?
Preventing tumor lysis syndrome focuses on lowering uric acid and other electrolyte imbalances that happen when cancer cells break down quickly. A few key strategies include aggressive hydration to help flush out uric acid and other byproducts through the kidneys. Allopurinol is often used to prevent the formation of uric acid from broken down purines. If uric acid levels are already high or need to be reduced quickly, rasburicase can be used because it directly breaks down uric acid into allantoin, which is more easily excreted. Electrolyte levels like potassium and phosphate also need to be closely monitored and controlled. Prevention is key, especially in high-risk patients undergoing chemotherapy for aggressive cancers.
So, if a patient has a diffuse large B cell lymphoma and we plan to do chemotherapy in him as soon as possible, what is the typical strategy before chemotherapy? How long before chemotherapy should we start allopurinol or rasburicase?
For high-risk patients like those with diffuse large B-cell lymphoma, allopurinol is often started 1 to 2 days before chemotherapy to help lower uric acid production right from the start of tumor breakdown. If the patient is at very high risk or already has high uric acid, rasburicase can be used immediately before or with the start of chemotherapy for rapid reduction of uric acid levels. Along with these medications, aggressive hydration is usually started a couple of days before chemotherapy to help flush out uric acid and other electrolytes. Monitoring and prevention typically start a day or two before chemo, but it depends on how urgent the treatment is and the patient's condition.
So, what is a typical dosing strategy for allopurinol in prevention of tumor lysis syndrome?
For tumor lysis syndrome prevention, the typical starting dose of allopurinol is usually around 300 milligrams per day, divided into smaller doses if needed. In some cases, higher doses up to 800 milligrams per day can be used depending on the patient's risk and kidney function. The treatment is typically continued throughout the chemotherapy and for several days after, until the risk of tumor lysis syndrome has passed. Monitoring uric acid levels during this period helps guide whether to adjust the dose or switch to rasburicase if necessary.
What are some key allopurinol adverse drug reactions that we should be vigilant about when starting allopurinol, especially when we are starting it for tumor lysis syndrome in doses like 300 milligrams or above?
Some key adverse reactions to watch for with allopurinol are hypersensitivity reactions, which can be serious. These include severe skin reactions like Stevens-Johnson syndrome or toxic epidermal necrolysis. There's also a risk of liver or kidney dysfunction, so it's important to monitor liver and kidney function regularly. When starting at higher doses, especially for tumor lysis syndrome, the risk of these side effects can increase. It's critical to ensure proper hydration and monitor for any allergic reactions or organ function issues.
Is allopurinol mainly eliminated from the body by the kidneys, or is it mainly metabolized in the liver?
Allopurinol and its active metabolite, oxypurinol, are primarily eliminated by the kidneys. That's why it's important to adjust the dose in patients with kidney problems to avoid accumulation and toxicity.
So, in a patient with chronic kidney disease, how should we adjust the allopurinol dosage?
In patients with chronic kidney disease, the dose of allopurinol is typically reduced to prevent accumulation of the drug and its metabolite. Usually the starting dose might be lowered to around 50 to 100 milligrams per day, depending on the severity of kidney impairment. It's important to monitor kidney function and uric acid levels closely to adjust the dose accordingly over time.
So, patients with CKD also have hyperuricemia, and does the uric acid goals in patients with impaired kidney function also the goal is to get it to less than 6 milligrams per deciliters of blood?
Yes, generally the target uric acid level is still below 6 milligrams per deciliter, even for patients with chronic kidney disease, especially if they have gout or other complications from high uric acid. However, the approach is more cautious because of the kidney function issues. You aim for the same target, but you must carefully titrate the dose and monitor both uric acid levels and kidney function.
So, in a patient who doesn't have gout and also doesn't have uric acid nephrolithiasis, Which indications exist for allopurinol if the patient has hyperuricemia?
Outside of gout or uric acid kidney stone, allopurinol can still be indicated for conditions where hyperuricemia might cause complications, like tumor lysis syndrome. It can also be used if there are signs of urate crystal deposition in tissues, even without full-blown gout. Sometimes it's used to prevent uric acid buildup in patients undergoing certain cancer treatments or in conditions like Lesch-Nyhan syndrome, where purine metabolism is disrupted.
If no other complications from the hyperuricemia exist in a patient with chronic kidney disease, which levels of hyperuricemia by itself, I mean asymptomatic hyperuricemia, warrant treatment?
In general, asymptomatic hyperuricemia doesn't always require treatment, even in patients with chronic kidney disease. There's no strict uric acid threshold that universally warrants treatment if the patient has no symptoms. However, if levels are extremely high, often above 13 milligrams per deciliter in men or 10 milligrams per deciliter in women, or if there's a rapid rise in uric acid, treatment may be considered to reduce the risk of complications like kidney damage or crystal formation over time. But in most cases, if there's no history of gout or kidney stones, mild or moderate hyperuricemia is often managed with lifestyle changes rather than medications.
What are the main lifestyle changing points that you would consider in a patient with mild to moderate hyperuricemia?
Key lifestyle changes include staying well hydrated to help the kidneys flush out uric acid. Also, reducing intake of purine-rich foods like red meat, organ meats, and certain seafood can help. Limiting alcohol, especially beer, is important since it can raise uric acid levels. And maintaining a healthy weight can also help manage uric acid levels. These changes can often reduce the need for medication in mild to moderate cases.
What is the mechanism behind raising uric acid levels with alcohol?
Alcohol increases uric acid levels in a few ways. First, when alcohol is metabolized, it competes with uric acid for excretion by the kidneys, which means less uric acid is eliminated. Second, alcohol can increase the breakdown of ATP, a molecule in the body, which produces purines that break down into uric acid. Finally, alcohol can increase lactic acid levels, and lactic acid further competes with uric acid for kidney excretion. All of this leads to higher uric acid levels in the blood.
So, briefly, increased lactic acid prevents uric acid excretion, and also increased ATP to AMP, and AMP is a purine which can be metabolized to uric acid, also increases uric acid production with alcohol abuse.
Exactly. The combination of those factors reduced kidney excretion due to lactic acid and increased uric acid production from purine metabolism converged to raise uric acid levels significantly with alcohol use.
So let's talk about some other aspects of tumor lysis syndrome. Hyperkalemia can cause fatal heart arrhythmias. Hyperphosphatemia, which can precipitate calcium phosphate precipitates in renal tubules and collecting system, and also lead to systemic hypocalcemia and the complications of that.
Exactly. Hyperkalemia from tumor lysis syndrome can cause dangerous heart arrhythmias and even cardiac arrest if not addressed quickly. Hyperphosphatemia, on the other hand, can lead to calcium phosphate crystals precipitating in the kidneys, which can cause acute kidney injury or worsen existing kidney problems. The drop in calcium levels caused by high phosphate can lead to muscle cramps, seizures, or even life-threatening complications like tetany. That's why managing all these electrolyte imbalances is crucial in tumor lysis syndrome to prevent severe complications.
So, what is the threshold for the product of calcium um, multiplied by phosphorus in the blood that would lead to precipitation of calcium phosphate?
The threshold for calcium phosphate precipitation is generally when the product of calcium.
Hello? So, what is the threshold for the product of calcium in the blood and phosphorus in the blood that can lead to precipitation of calcium phosphate crystals in tissues.
The threshold for calcium phosphate product that can lead to precipitation of calcium phosphate in soft tissues, including blood vessels, skin, lungs, and kidneys, is generally considered to be calcium phosphorus product, Ca times P, 55 to 60 milligrams per square LDL. Why is this important? A calcium phosphorus product, 55 milligrams per DLSCAR, is associated with soft tissue and vascular calcification, increased mortality, especially in chronic kidney disease, CKD, and end-stage renal disease, ESRD. How to
So when the calcium phosphorus product exceeds 55 milligrams squared per deciliters squared, calcium phosphate precipitates out of solution. This is called metastatic calcification, and the main form of the precipitation is hydroxyapatite that has 10 calcium atoms in it and 6 phosphate groups in it, plus 2 hydroxy groups. So 2 minus 1s, 6 minus 3s, that is minus 20, and 10 calciums, that is plus 20. The tissues most vulnerable to metastatic calcification are first vasculature. This causes vascular stiffening and arterial calcification. Also kidneys, gastric mucosa, and lungs. That means high pH tissues because calcium phosphate precipitates when the pH is alkalotic. Alkalosis increases precipitation of hydroxyapatites. So we know that alkalosis promotes the precipitation of hydroxyapatite, for instance, in metastatic calcification. Is there any correlation between this and the function of alkaline phosphatase, which promotes bone formation?
Excellent and insightful question. Yes, there is a conceptual and biochemical connection between alkalosis, alkaline phosphatase activity, and hydroxyapatite precipitation, though they operate through somewhat different mechanisms and contexts. Here's a breakdown. 1. Alkalosis and hydroxyapatite precipitation in soft tissues. Mechanism. In alkaline environments, phosphate, PO-carbonate, and calcium precipitates ions are more prone to combine and precipitate as hydroxyapatite. Ca2 plus PO4-3s, right arrow Ca10, PO4-6OH2. Tissues with relatively high pH like lungs, kidneys, gastric mucosa are common sites of metastatic calcification, especially when the CAP product, 55 to 60 milligrams per deciliter squared. Alkalosis, e.g. metabolic alkalosis or localized tissue alkalinity, increases free phosphate and promotes precipitation. 2. Alkaline phosphatase and bone mineralization. Function. Alkaline phosphatase, ALP, is an enzyme primarily produced by osteoblasts and plays a critical role in bone formation. It hydrolyzes pyrophosphate, PPI, an inhibitor of mineralization, into phosphate pi, thus increasing local phosphate concentration. Al2-pi. By removing pyrophosphate and increasing inorganic phosphate, ALP favors hydroxyapatite crystal deposition in bone matrix. Alkaline pH. ALP is optimally active at alkaline pH, pi 9 to 10, hence the name. Bone-forming surfaces, osteoid, often have a slightly alkaline microenvironment during active mineralization. Connection between alkalosis and ALP activity. Aspect, alkalosis in tissues, alkaline phosphatase activity. Environment, high systemic or local pH.
So it also stands to reason that metastatic calcification in hypercalcemia or hyperphosphatemia also increases in alkalosis situations, alkalosis situations. Okay, so we were talking about tumor lysis syndrome and hypocalcemia, hyperphosphatemia, hyperkalemia, and hyperuricemia in tumor lysis syndrome. How can one address all these electrolyte imbalances in a patient with tumor lysis syndrome?
Managing tumor lysis syndrome focuses on preventing and correcting these electrolyte imbalances. The main steps include aggressive hydration to flush out excess electrolytes, medications like rasburicase or allopurinol to reduce uric acid, and specific treatments for each imbalance. For hyperkalemia, you can use medications that shift potassium into cells or remove it from the body. For hyperphosphatemia, phosphate binders can help. For hypocalcemia, you typically correct the phosphate first, and then only give calcium if symptoms are severe due to the risk of worsening other imbalances. Close monitoring in a hospital setting is usually necessary.
We talked about rasburicase, which is a recombinant version of urate oxidase. Urate oxidase is not present in humans but is present in many other mammals, and it converts uric acid into allantoin. Allantoin is 5 to 10 times more soluble than uric acid and therefore far less likely to precipitate in the kidneys.
Exactly. That's why rasburicase is so effective in reducing the risk of uric acid crystal formation in the kidneys, which can lead to acute kidney injury. By breaking down uric acid into allantoin, which is much more soluble, it helps protect kidney function during rapid cell breakdown, like in tumor lysis syndrome.
So we know that hypoxanthine and xanthine are also more soluble than uric acid. If allantoin is 5 to 10 times more soluble than uric acid, how many times are hypoxanthine and xanthine more soluble than uric acid?
Hypoxanthine is significantly more soluble than uric acid, making it much less likely to crystallize. Xanthine, on the other hand, has a solubility closer to that of uric acid, but still somewhat more soluble. To put it simply, hypoxanthine is more soluble than both uric acid and xanthine, while xanthine is only slightly more soluble than uric acid. So overall, allantoin is by far the most soluble. Hypoxanthine is also quite soluble, and xanthine is only a little better than uric acid in terms of solubility.
So the drugs that are inhibitors of xanthine oxidase, we have allopurinol, which is a purine decoy that competitively inhibits xanthine oxidase, and febuxostat, which is not a purine lookalike. It's a non-purine inhibitor of xanthine oxidase.
That's correct. Allopurinol mimics purines and competes with them for xanthine oxidase, blocking the enzyme's ability to convert hypoxanthine and xanthine into uric acid. Febuxostat, on the other hand, binds to a different site on the enzyme. Because it's not a purine analog, it works through non-competitive inhibition, effectively reducing uric acid production as well. Each approach can be useful depending on the patient's condition and tolerance to either drug.
So, in terms of the enzyme kinetics, the competitive inhibition that allopurinol does on xanthine oxidase, in what ways is it different than the non-competitive inhibition that febuxostat brings about?
In competitive inhibition, like with allopurinol, the inhibitor competes directly with the substrate for the enzyme's active site. That means increasing the substrate concentration can overcome the inhibition. In non-competitive inhibition, like with febuxostat, the inhibitor binds to a different part of the enzyme, not the active site. As a result, increasing the substrate concentration won't overcome the inhibition. It effectively reduces the enzyme's overall activity no matter how much substrate is present. So with competitive inhibition, enzyme function can be restored by adding more substrate, but with non-competitive inhibition, the enzyme's capacity is reduced regardless of substrate levels.
So we can say that in non-competitive inhibition, the Vmax is decreased, but in competitive inhibition, the Vmax stays the same. What can we say about the Km value in competitive versus non-competitive inhibition?
Exactly. In competitive inhibition, the Km value increases because the substrate has to outcompete the inhibitor to occupy the active site, so more substrate is needed to reach half of Vmax. In non-competitive inhibition, the Km stays the same because the inhibitor doesn't compete with the substrate for the active site. However, Vmax decreases since the enzyme's overall efficiency is reduced, no matter how much substrate is present. That's the key difference between the two.
So what is the difference between allosteric inhibition and non-competitive inhibition?
Great question. They're similar but not identical. In non-competitive inhibition, the inhibitor binds to a site that's not the active site, but it doesn't necessarily change the shape of the enzyme. In allosteric inhibition, the inhibitor binds to a specific regulatory site, called an allosteric site, causing a conformational change in the enzyme structure. That structural change reduces the enzyme's activity. So, non-competitive inhibition doesn't always change the enzyme shape, while allosteric inhibition specifically relies on that structural shift to reduce activity.
So is allosteric inhibition always a form of non-competitive inhibition?
It often is, but not always. Many allosteric inhibitors act in a non-competitive way, since they bind somewhere other than the active site and lower the enzyme's activity regardless of substrate concentration. However, some allosteric regulators can also influence substrate binding affinity, making the effect more complex. So while most allosteric inhibition is non-competitive, it's not necessarily always strictly non-competitive in the traditional sense.
What about irreversible inhibition? Is irreversible inhibition always non-competitive?
Not necessarily. Irreversible inhibition means the inhibitor permanently binds to the enzyme, usually at the active site or a crucial region, preventing it from functioning. That can happen in a competitive or non-competitive manner, depending on where the inhibitor binds. So, irreversible inhibition can be either competitive or non-competitive. What makes it irreversible is that the enzyme is permanently inactivated.
So what is the change in the Km and Vmax values for an irreversible
In
enzyme inhibitor?
With irreversible inhibitors, the enzyme is permanently inactivated. This effectively reduces the total amount of functional enzyme. As a result, Vmax decreases because there are fewer active enzymes available. However, Km usually remains unchanged because the remaining active enzymes still have the same affinity for the substrate. So the main impact of an irreversible inhibitor is a permanent reduction in Vmax.
So Vmax is reduced and Km stays the same in non-competitive inhibition and also in irreversible inhibition. So in terms of enzyme kinetics, these two look a lot similar to one another.
Exactly. Kinetically, irreversible inhibition looks a lot like non-competitive inhibition because both reduce Vmax without changing Km. The key difference is that non-competitive inhibition is reversible, meaning the inhibitor can eventually detach, but with irreversible inhibition, the enzyme is permanently out of commission. But from a kinetic standpoint, they do look very similar.
So, a general rule for treating hypocalcemia in tumor lysis syndrome is, as a rule of thumb, we do not correct hypocalcemia by calcium infusions or administration of 1,N,25 dihydroxycholecalciferol until we have evidence of neuromuscular irritability.
Exactly. That's a key principle. In tumor lysis syndrome, the focus is on managing the underlying cause and monitoring for symptoms of hypocalcemia rather than aggressively correcting calcium levels. Treatment is only recommended if there are clear signs of neuromuscular irritability, like tetany or seizures.
So, tetany and seizures are late signs of neuromuscular irritability. However, we can monitor neuromuscular irritability with a positive Chvostek or Trousseau's sign. How do we assess for a Chvostek or Trousseau's sign?
To assess for Chvostek sign, you gently tap the facial nerve just in front of the ear. The positive sign is when the facial muscles twitch. For Trousseau sign, you inflate a blood pressure cuff around the arm above systolic pressure for a few minutes. A positive sign is when the hand and fingers spasm into a characteristic position. These tests can indicate neuromuscular irritability due to low calcium levels before more severe symptoms appear.
So, how long should we keep the blood pressure cuff elevated above the systolic blood pressure to evaluate for a Trousseau's sign?
Typically, you keep the blood pressure cuff inflated for around 3 minutes to check for Trousseau's sign. If the hand and fingers go into spasm during that time, it's considered a positive sign of latent tetany due to hypocalcemia.
So, treating hyperphosphatemia in tumor lysis syndrome, we can use sevelamer, which is a phosphate binder that is also used in chronic kidney disease, and also glucose plus insulin, which is used in treating hyperkalemia, can be used to treat hyperphosphatemia as well.
Exactly. Sevelamer is a phosphate binder commonly used in chronic kidney disease to reduce phosphate absorption. It can also be used in tumor lysis syndrome when hyperphosphatemia is a concern. Glucose plus insulin is typically used for hyperkalemia, but you're right that it can sometimes reduce phosphate levels indirectly by shifting both potassium and phosphate into cells temporarily. However, managing phosphate directly with binders like sevelamer is the standard approach.
So, what is a typical dosing regimen for sevelamer in a patient with tumor lysis syndrome, and how do we administer it?
For tumor lysis syndrome, the typical dosing regimen of allopurinol is around 600 to 800 milligrams per day.
No, no,
Usually,
not allopurinol, but sevelamer, which is a phosphate binder.
got it. Sevelamer is a phosphate binder used to control phosphorus levels in patients with chronic kidney disease, including those on dialysis. The typical dosing regimen often starts at 800 to 1600 milligrams taken 3 times daily with meals. The dose is adjusted based on serum phosphorus levels, so it can vary. The key is to take it with meals, so it binds dietary phosphate in the gut and reduces absorption.
So, if a patient has tumor lysis syndrome and is hyperphosphatemic because of that, and he is also NPO and only on serum therapy, IV serum therapy, does sevelamer have any effect in reducing this patient's hyperphosphatemia?
If the patient is NPO, meaning they are not taking anything by mouth, sevelamer won't be effective because it works in the gut by binding dietary phosphate. Without oral intake, there's no phosphate from food to bind to. In that case, managing hyperphosphatemia usually involves strategies like using intravenous medications or dialysis to remove excess phosphorus directly from the blood.
What intravenous medications can be used to reduce phosphate?
There aren't direct intravenous phosphate binders like sevelamer. Instead, for severe hyperphosphatemia, the most effective approach is hemodialysis or continuous renal replacement therapy, which can rapidly lower phosphate levels by filtering it out of the bloodstream. Managing phosphate levels with IV therapy often focuses on correcting other biochemical imbalances, like calcium, but it doesn't directly bind phosphate. So dialysis is the main intervention when the gut can't be used for phosphate binding.
So, in addition to phosphate levels, uric acid levels, and potassium levels, LDH levels also increase in tumor lysis syndrome.
Yes, exactly. Tumor lysis syndrome happens when a large number of tumor cells break down rapidly, releasing their contents into the bloodstream. This leads to high levels of phosphate, potassium, and uric acid, and also increases LDH, which is a marker of cell breakdown. Managing all these abnormalities is key in treating tumor lysis syndrome.
So, in contrast to calcium phosphate, which precipitates in an alkalinic environment, uric acid with a pKa of 5.4 precipitates
Right,
in an acidic environment.
exactly. Uric acid tends to precipitate in more acidic conditions because its pKa is about 5.4. That means when the environment's pH drops below that value, more of the uric acid is in its neutral form, which is less soluble and more likely to crystallize.
So, what does a pKa of 5.4 mean?
The pKa is the pH at which half of the molecules of a substance are in their acidic form and half are in their conjugate base form. For uric acid, a pKa of 5.4 means that at a pH of 5.4, half of the uric acid is protonated, neutral form, and half is deprotonated, its ionized, more soluble form. When the pH drops below 5.4, more uric acid stays in its neutral form, which is less soluble and can lead to precipitation.
So, we know that calcium phosphate precipitates in an alkalinic urine, but uric acid precipitates in an acidic urine. Knowing this, in tumor lysis syndrome, do we try to alkalinize the urine or try to make it more acidic?
In tumor lysis syndrome, we try to alkalinize the urine. That's because tumor lysis releases a lot of uric acid, and by making the urine more alkaline, we keep uric acid in its more soluble ionized form. That helps prevent uric acid crystals from forming and protects the kidneys.
So we know that calcium phosphate precipitates in an alkalinic environment and uric acid precipitates in an acidic environment. In tumor lysis syndrome, we try to alkalinize urine to decrease the precipitation of uric acid crystals, although we know that it can produce more calcium phosphate crystals. Why is it?
This is a brilliant observation and exactly the clinical paradox in tumor lysis syndrome, TLS. Alkalinizing the urine may help prevent uric acid nephropathy, but can promote calcium phosphate precipitation. And this trade-off has significant clinical consequences. Let's break down the biochemistry and clinical reasoning. 1. Uric acid versus calcium phosphate solubility in different pH. Compound, solubility in acidic pH. That, solubility in alkaline pH. Better solubility, uric acid, poor, precipitates as uric acid crystals. Improved, more ionized as soluble urate. Calcium phosphate, CaPO4, better solubility, poor, precipitates as hydroxyapatite. 2. Tumor lysis syndrome pathophysiology. Massive tumor cell breakdown, release of nucleic acids catabolized into uric acid. Phosphate binds calcium, risk of CaPO core precipitation. Potassium, hyperkalemia, all can lead to acute kidney injury. 3. Why alkalinize the urine? Uric acid is poorly soluble at low pH, 5.5, crystallizes in renal tubules, uric acid nephropathy. Alkalinizing the urine, pH 6.5, converts more uric acid to soluble urate form, helps prevent urate nephropathy. But at higher pH, calcium phosphate, CaPOC, becomes less soluble, risk of metastatic calcification in renal tubules, nephrocalcinosis, and worsening AKI. 4. Clinical recommendation shift. Historically, urine alkalinization, e.g. with sodium bicarbonate, was commonly used to prevent uric acid nephropathy. Now, Urine alkalinization is no longer routinely recommended in TLS management because rasburicase, a recombinant urate oxidase, rapidly degrades uric acid to allantoin, which is very soluble at all pH levels. Thus, no need to alkalinize urine. This avoids the increased risk of KPO4 precipitation. Current standard of care in TLS.
So the current standard of care in TLS is to decrease uric acid by rasburicase, which is preferred, or allopurinol. Maintaining hydration with IV fluids 2 to 3 liters per meters squared of body surface area in a day. Monitoring electrolytes with drawing frequent labs. And urine alkalinization is nowadays generally avoided unless uric acid nephropathy is a significant concern and no rasburicase is available. So another point to add before closing the discussion on tumor lysis syndrome is that because of the pKa of approximately 5.5 of uric acid, it crystallizes in acidic urine. Now, acidic urine is typically found in distal tubules and collecting ducts. That is where the acidifying of the urine occurs. So, uric acid crystals typically obstruct the distal tubules and collecting ducts in the nephrons, and they do not precipitate in proximal tubules or the loop of Henle.
Exactly. That's a key point. The acidic environment of the distal tubules and collecting ducts favors the precipitation of uric acid crystals. This can lead to obstruction and potentially acute kidney injury if not managed promptly. So taking measures to maintain adequate hydration and alkalinize the urine can help prevent these complications in tumor lysis syndrome.